Hello again, this is Lecture 4 in the Principles of Cardiac Sonography 2 unit. The lecture is entitled Hypertrophic and Restrictive Cardiomyopathies. There are 4 parts to this lecture. Part 1 is a brief introduction to some aspects of the microanatomy of the heart. This will be an extension of the cardiac anatomy already taught in the course and serve as a lead-in to other topics in this lecture. In Part 2, we will look at hypertrophic cardiomyopathy, causes and features of hypertrophic cardiomyopathy, as well as echocardiographic imaging in this setting. In Part 3, we will look at restrictive cardiomyopathy, its features, causes, and echo imaging in this setting. And finally, in Part 4, a short description of 3 other kinds of cardiomyopathy will be given. There are 4 lecture learning outcomes. That is, following this lecture you will be able to 1. Describe certain features of cardiac muscle microanatomy. 2. Explain the abnormal features characteristic of hypertrophic and restrictive cardiomyopathy. 3. Relate the key echocardiographic images required in hypertrophic and restrictive cardiomyopathy. And 4. Describe RV dysplasia, LV non-compaction, and Takotsubo's cardiomyopathy. Textbooks and their relevant chapters for this lecture are once again Essential Echocardiography, Chapter 9, and the Textbook of Clinical Echocardiography, also Chapter 9. Introduction. Cardiac myocytes are the cells that perform the mechanical action of the heart. Each myocyte is filled with long, parallel myofibrils that contain numerous protein-rich myofilaments. Myosin and actin are the 2 major myofilaments that enable the myofibrils to shorten and lengthen, that is, to contract. The highly organized arrangements of myofilaments give cardiac muscle a striated appearance under the microscope. A sarcomere is a portion of the myofibril and is the basic mechanical unit of each myocyte. That is, a sarcomere is the section of the myofibril that is capable of performing all the functions of cardiac muscle. The illustration on the top left of this slide is of myocytes with myofibrils. The illustration below this is of myofibrils composed of myofilaments and the section of the myofibril called sarcomere. The microscopic image shows a longitudinal section of cardiac muscle with its distinctive striations. The heart has the ability to increase in size, that is, to remodel. Changes in size, shape, and function often occur after cardiac injury. The myocyte is the major cardiac cell affected by remodeling. In the last lecture, we considered remodeling due to myocardial infarction and to dilated cardiomyopathy. In this lecture, we will consider remodeling for other reasons. Cardiac hypertrophy. Cardiac hypertrophy refers to an increase in thickness and mass of the heart wall. Hypertrophy of LV myocytes is the most common type of hypertrophy. This is often due to an increase in the force acting against myocytes that comprise the left ventricle. Diseases that increase the afterload of the heart, such as hypertension and aortic valve stenosis, cause left ventricular hypertrophy. In hypertension and aortic stenosis, hypertrophy is a reactive process. Hypertrophy decreases the stress on the myocytes that comprise the walls of the left ventricle by increasing the wall thickness. This follows Laplace's law, which states that wall stress or tension is an inverse function of wall thickness. The law reads, tension equals pressure multiplied by radius divided by wall thickness times 2. That is, the greater the wall thickness, the less the wall stress. Left ventricular hypertrophy is more common than right ventricular hypertrophy. In response to an increase in afterload, the LV wall often thickens and does so in one of two ways. Concentric hypertrophy. This is an increase in LV mass and an increase in the relative wall thickness compared to the chamber size. In this case, individual myocytes increase in width more than in length. Eccentric hypertrophy. This is an increase in LV mass with a relatively normal wall thickness compared to chamber size. This illustration helps distinguish these two forms of hypertrophy. In concentric hypertrophy, sarcomeres are added in parallel and the relative wall thickness is increased. With eccentric hypertrophy, sarcomeres are added in series without an increase in relative wall thickness. Left ventricular hypertrophy can be physiological or pathological. Physiological LV hypertrophy can occur with athletic training and during pregnancy. Pathological hypertrophy can occur with pressure overload, like in hypertensive heart disease, valvular stenosis, for example with aortic stenosis. As mentioned, both of these conditions increase afterload. This echo image shows the most characteristic finding in a patient with concentric hypertrophy, a uniform increase in LV mass. That is, the increase in wall thickness is the same throughout the left ventricle, and this is an important feature to recognize. Hypertrophic cardiomyopathy. As mentioned in the last lecture, cardiomyopathy is a non-specific term used to indicate cardiac muscle disease, excluding disease due to ischemia or valve pathology. The cause of a cardiomyopathy may or may not be known. There are 4 general classes of cardiomyopathy, although when the disease is advanced, the morphology and functional features may overlap. Hypertrophic cardiomyopathy is the subject of the second part of this lecture. Causes. Hypertrophic cardiomyopathy is a genetic disease. That is, it is a result of abnormalities in a person's genome. In hypertrophic cardiomyopathy, the genes that code for contractile proteins of the cardiac myocardium are abnormal. Carriers have an increased risk of sudden death, especially during exercise. It is important to recognize that hypertrophic cardiomyopathy is not due to elevated blood pressure. That is, it is not the result of hypertension. The primary features of hypertrophic cardiomyopathy include asymmetric left ventricular hypertrophy, that is, hypertrophy that is greater in certain parts of the LV than others. Other features are a normal LV ejection fraction, impaired LV diastolic function, and dynamic subaortic obstruction. The illustration on the right of the slide highlights one of the primary features of hypertrophic cardiomyopathy. It shows two hearts, one of normal size, the other with significant asymmetric hypertrophy, where the septum is affected most significantly. In hypertrophic cardiomyopathy, hypertrophy of the septum is often most significant, though significant apical hypertrophy can also occur. A common feature is that with significant septal or significant apical hypertrophy, often there is basal posterior LV wall normal thickness, that is, the basal posterior wall is spared. These two images highlight two other primary features. Firstly, a normal ejection fraction. Once again, note the significant septal hypertrophy and near normal basal LV wall thickness. And secondly, impaired LV diastolic function, where the image on the right shows the peak mitral E wave velocity to be less than the peak A wave velocity. Another primary feature of hypertrophic cardiomyopathy is dynamic subaortic obstruction. This results in an increase in the blood flow velocity proximal to the aortic valve. The increased velocity is highest in mid to late systole. This feature can be altered by loading conditions. That is, it can be reduced by a reduction in LV contractility or increased by an increase in LV contractility. There are three ways to classify hypertrophic cardiomyopathy. Non-obstructive. If the gradient is less than 30 millimeters of mercury, that is 2.7 meters per second at rest, it is classified non-obstructive. Obstructive. This is if the outflow gradient exceeds 30 millimeters of mercury at rest. Or provocable. This is if the gradient is less than 30 millimeters of mercury, but obstruction occurs with exercise or Valsalva. Dynamic subaortic obstruction. The increased LV outflow gradient in obstructive hypertrophic cardiomyopathy results in a dynamic obstruction, that is, an obstruction that gets progressively worse throughout systole. A dynamic obstruction is often associated with systolic anterior motion of the anterior mitral valve leaflet. Systolic anterior motion, or SAM, is likely due to the suction force that results from the increased flow velocity in the LVOT and an abnormal mitral valve structure. SAM is almost always associated with some degree of mitral regurgitation due to the abnormal motion of the anterior mitral leaflet towards the interventricular septum, which prevents coaptation, that is, closure, of the mitral leaflets. The 2D image at the top of this slide from a patient with dynamic outflow tract obstruction shows systolic anterior motion of the anterior mitral leaflet in mid to late systole. The colour image shows the consequent turbulent flow in the LVOT as well as eccentric mitral regurgitation. The M-mode image at the bottom also shows SAM as well as mid-systolic closure of the aortic valve leaflets, which can also occur in dynamic outflow tract obstruction. This slide, which is from the textbook, simply illustrates some of the features I've mentioned that are typical in hypertrophic cardiomyopathy. Signs and symptoms. Hypertrophic cardiomyopathy may cause angina, exercise intolerance, and if obstructive, it can cause syncope. Atrial fibrillation may be a long-term result, and a systolic murmur is often heard due to the turbulent LVOT flow and also to any mitral regurgitation. (2D) imaging. Quantitative 2D measurements should include linear LV dimensions. Remember, hypertrophic cardiomyopathy is associated with asymmetric hypertrophy. The measurements on the 2D image at the top right of this slide indicate a patient with hypertrophic cardiomyopathy. The measurements on the image below do not, as the measurements indicate concentric hypertrophy. LVEF and LA volume measurements should also be made. M-mode imaging often shows systolic anterior motion of the mitral valve and premature aortic valve closure very well. Doppler imaging is also important. An LVOT gradient needs to be measured. This will almost always require the use of continuous wave Doppler, as velocities can exceed 4 and 5 meters per second in the LVOT. Diastolic function measurements are also valuable. Earlier I mentioned that obstruction can be provoked, that is, uncovered by stress. The images on the left of this slide, which are from the textbook, give an example of provocable hypertrophic cardiomyopathy, with the peak LVOT gradient increased by more than 2 times with exercise. The Valsalva maneuver is another way to uncover obstruction. A Valsalva is a forceful expiration against a closed airway, held for 5 or 6 seconds. A Valsalva is used, for example, to equalize the inner ear pressure with the ambient water pressure when diving. With Valsalva, there is an initial rise in intrathoracic pressure and an early increase in stroke volume. This may help to increase and uncover the LVOT obstruction in hypertrophic cardiomyopathy. During the middle of the effort, stroke volume falls as systemic venous return is reduced. However, another rise in the LVOT gradient may be seen immediately after Valsalva, when blood can return to the heart normally again. A technical tip. It may be difficult to distinguish an LVOT signal from an MR signal, that is a mitral regurgitant signal, in obstructive hypertrophic cardiomyopathy. Both signals may be present. To differentiate between them, remember the mitral regurgitant signal starts earlier and ends later, which gives it a different shape to the LVOT signal. That concludes part 2 of the lecture. In part 3, I will discuss restrictive cardiomyopathy. Features. Restrictive cardiomyopathy is characterized by extreme ventricular stiffness. This results in severe diastolic dysfunction. While left ventricular ejection fraction may be preserved, heart failure occurs due to the significant diastolic dysfunction. This is often referred to as heart failure with preserved ejection fraction. Patients with restrictive cardiomyopathy present with features of heart failure, such as shortness of breath, reduced exercise tolerance, and peripheral edema. A number of different diseases can cause restrictive cardiomyopathy. Often, the diseases are responsible for an abnormal deposition of protein in the myocardium, or for an increase in myocardial fibrosis, that is, an abnormal amount of collagen in the myocardial tissue. This leads to 1. Increased myocardial thickness, and 2. Reduced myocardial compliance. The diseases often responsible for restrictive cardiomyopathy include amyloidosis, which is a multi-organ disease that often affects the heart. It affects the heart by depositing amyloid proteins within the myocardium. Fabry's disease, a lysosomal storage disease wherein glycolipids build up in the heart. And sarcoidosis, which is a disease of the immune system where white blood cells, specifically granulomas, form in the myocardium. Echocardiography in restrictive cardiomyopathy. The typical echo features include thickened ventricles that may display an increased degree of myocardial speckling, abnormal diastolic function, which, as mentioned, is the hallmark of restrictive cardiomyopathy, biatrial dilatation, and an increased tricuspid regurgitant jet velocity that relates to the patient's elevated pulmonary pressure secondary to their poor LV compliance. Quantitative 2D measurements needed in these patients include LV dimensions, left ventricular ejection fraction, and LA volume. Several Doppler measurements are needed in these patients. These include mitral valve E and A velocities and E over A ratio. A typical restrictive pattern, as shown on the right of the slide, includes a high E wave velocity and a low A wave velocity. An A wave velocity less than twice the velocity of the E wave. The E wave deceleration time in these patients is often less than 200 milliseconds. Septal and lateral E prime measurements are important. With restriction, they are certain to be significantly reduced, often to values less than 5 centimeters per second, as per the image on the bottom of this slide. And typically, the E over E prime ratio is significantly elevated. Colour and continuous wave Doppler measurements of the tricuspid valve regurgitation are also required in order to estimate pulmonary pressure. That's the end of part 3 of the lecture. In part 4, I'll briefly discuss 3 other cardiomyopathies that have been recognised more recently. A more detailed knowledge of the 3 main forms of cardiomyopathy that have already been discussed, that is, dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy, is more important than the following 3. Nonetheless, it is important that they are introduced. Arrhythmogenic right ventricular dysplasia. Arrhythmogenic RV dysplasia is a rare genetic form of cardiomyopathy that predominantly affects the right ventricle. In ARVD, RV muscle is replaced with fibrofatty material, which leads to RV dilatation, dysfunction, and predisposes to ventricular arrhythmias like VT and VF. The image on the right shows the typical microscopic features of ARVD, with infiltration of fibrofatty material, the white areas, among the pink muscle cells. Echocardiographic features of ARVD include prominent RV trabeculations, RV dilatation, RV systolic dysfunction, and small RV aneurysms may be seen. Left ventricular non-compaction. LV non-compaction is a rare genetic form of cardiomyopathy. Non-compaction is due to a failure of the normal compaction process that occurs during fetal cardiac development. It affects the LV and is characterized by prominent myocardial trabeculations with deep recesses that communicate within the ventricle. The clinical presentation may include heart failure, embolic events, and arrhythmias. These apical 4-chamber images, which are from Catherine Otto's textbook, show prominent myocardial trabeculations and blood flow within the trabeculated myocardium. Takotsubo cardiomyopathy. Takotsubo cardiomyopathy is an acute form of cardiomyopathy induced by significant psychological or physiological stress, and for this reason is sometimes called broken heart syndrome. Most often, it affects women of a mature age. Clinical signs are similar to an MI, which include ECG changes such as ST elevation and elevated serum cardiac biomarkers. Fortunately, Takotsubo cardiomyopathy is transient in nature and may resolve within approximately 8 days if treated promptly. The hallmark features of this type of cardiomyopathy are 1. Apical ballooning, and secondly, preserved basal contractility. The echo image on the right highlights the apical LV ballooning. The angiogram image shows normal basal contractility with apical ballooning and the consequent characteristic anatomy. The lower right image is an octopus pot called a takotsubo, which is what this condition was first described as resembling. In conclusion, this lecture has involved, or rather included, 4 parts. Part 1 included aspects of the microanatomy of the heart, especially cardiac myocytes, and details related to LV hypertrophy in reaction to increased afterload. Parts 2 and 3 included a description of hypertrophic and restrictive cardiomyopathies, their causes, typical features, and echocardiographic imaging. Finally, in Part 4, 3 other more recently described forms of cardiomyopathy were described.